cloud. Okay, so thank you. So this is the HL7 antitrust policy. We'll let people take a second to read it. We're supposed to display it as part of all our calls, all our HL7 calls. All right. So Karen, do you want me to go ahead or did you want to move these along?
Yeah, I think you can go ahead.
Right. Okay. So one of the things that we've been working on or planning is the profiling. As you know, as we presented in the way the profile is right now, the approach in the past was to profile each separate condition, which will end up with a huge slew of profiles. So what we've done is we think we're taking a different approach, which is similar to how Gravity is approaching it, where we will profile the resource. So for example, we'll profile the MCC, the condition resource. And actually we're profiling on top of US core for condition. And then we will provide a library of value sets that can be used in the condition.code element, for example, and other places as well. That will provide value sets for different kinds of conditions. So there will be a value set for chronic kidney disease, value set for chronic pain, those kinds of things. So that's the approach that we're planning on taking, and we're hoping to get this written up for the profile, and the profile to, I'm sorry, in the MCC profile to go through the January ballot as a comment only ballot using this approach. Similarly with goals, and we're going to do this across, all the profiles that we do. Today we want to talk about a little bit about guidance on binding for goal that target measures. So that's one of the things that we're starting to look into, especially as we go through the COVID work. COVID is one of the long COVID is one of the conditions that we are doing as part of our multiple chronic condition profiles. So that's one area. We've been working on collecting long COVID symptoms. We have a TEP group that which include caregivers as well, that we've been using, their expertise in order to get the symptom value sets beefed up. And then we started to work on long COVID interventions. So that's work that's currently underway right now. Next slide, Karen. So as I described with the, the way in which we're planning, we're thinking that we're going to approach the profiling. We'll profile the condition resource and then provide a library of value sets that will go, for example, in the condition.code elements. And for MCC conditions, we're profiling on top of US core. So whenever the library, if the condition that is being used is not part of that library, then the default will be SNOMED CT or ICD-9 codes, which are parts which are constrained or used by US core condition. So this is an extensible value set in US core. That's the approach we think we will take. Any questions on this so far? Okay. So one of the things, Karen, next slide, please, for goal. So goal that target measure value set is one of the areas in which that we'll be trying to identify value sets. And of course, it's tied to, context as to what the goal is and what type of goal it is. So this is an area that we think we'll profile in goal. And I brought the resource up here just so we can be familiar, just get a view of how the resource is set up for the goal target. And then there's a measure, meta measure is a codable concept. We can create value sets for that. And then also in the specific detail, there's quotable concept there as well, where we can get really specific in order to explain a measurable goal. So I put some examples in like the next 2 slides just to show you, and look at, if you notice, detail is a choice element. So can you go back a little bit? So here, for example, in my example, you can either have a detail range, for something that is very, that can be very, very straightforward. And then also detail can also be a quotable concept. So you can go to the next slides, and as well as any of those other data types. So this is an example of how in the fire spec, this is a person's who goal is to keep the body weight, or to have the body weight between 100 to 155 pounds. And this is how, you would actually indicate the precise range for that particular goal. And then the next slide is how I'm trying to depict, for example, this person goal is for the patient to be on a low sodium diet. And then you can go into detail as to specifically that you want this sodium restricted diet to be 40 milliequivalents. And this is using quotable concepts and the quotable concept data type for this. This is just an example of the ways in which FIRE can capture the specifics of goal, target, and measure.
So Emma, can I interject for a quick question here? So the code of 541230004, is it strictly for sodium restricted diet 40 milligram equivalent?
Yes. So that's
what I mean. So that means that if there isn't a SNOMED code for the exact sort of milligrams equivalent of sodium diet restriction, you can't you don't have a way of expressing it. What is the solution?
So remember that the data type is a quotable concept.
Yeah.
Quotable concept has coding and text. So if you don't have a specific code, you can use the text element within quotable concept to express what you need with just text.
All right. Okay. Right. Thanks.
It's structural. You know what I'm saying? So you can still use for that text.
Right. Thanks.
Yeah. And when we start to talk about barriers, I had a long conversation yesterday with Lloyd about that particular thing, quotable concept and text. Yeah, but thanks for the question, Stephen. So next slide, please, Karen. Yes, speaking about barriers, any questions about goals and our approach to the profiling and the value set so far? All right. So speaking about barriers and supportive factors. Okay, so we, as you know, we've taken this conversation to patient care work group fire calls. We've had this conversation during our technical connectathon in January, and we still have goal, as part of the May technical connectathon that's coming up, and clinician on fire. So 4 barriers. So one of for people who have not been following this conversation so closely. So there were suggestions on, the whole context is this. There are reasons why something that the patient needs to do or something that is needed for the patient cannot be done. And it's because of some barrier that stands in the way. So an example that was given was, for example, there's a patient who wants to walk 2 miles 3 times a week. That's their goal. But they had a fractured hip or have, really bad osteoarthritis in their knee. So they're unable to walk those 2 miles 3 times a week to be. So there's something that's impeding them from reaching their goal. So when we had this conversation, well, it came up that there could be something that impedes lots of other types of things that the patient needs. So for example, you might have a medication request where the prescription is written, but the patient cannot afford the copay. Or you might have a service request where the patient needs some sort of procedure or something, but there's something that's stopping them from getting to the, to get the procedure done. So with that in mind, one of the suggestions was that maybe we can profile observation, so say what that thing is, and then have that observation point to the thing that is being impeded. We took that to fire workflow and was told that no, that's not the way to go. And I believe Rob Howsam was also, who is an OO co-chair, was saying that was in one of the intent for observation. So we've been pushed back to try to use an extension in order to do this. And by us doing it with an extension, and this is the conversation that I've been having with the Fire Eye people, is by us doing an extension, we can do an extension for barrier as well as an extension for protective factors. Did I said supportive, didn't I? I should have said protective. And I can't rename the JIRA, but anyway, so for protect, it's supposed to be for protective factors. So in the conversations about the extension, so I've been told that and I actually worked with Jose, who's on the fire workflow team yesterday, where he started to build it up as the barrier, the one for barrier as an extension. You can specify all the resources that should be able to use this extension. So for right now, we're putting it on request type resources as well as goal. And then also we can make the data type of that extension a quotable reference in which you can reference another resource as the thing which could be referencing an observation that is the thing that is the barrier. We can either use a quotable concept where you can have a code that can say what that barrier is, or you can also have text, just straight text, as we discussed earlier, to say what that barrier is as well. And another part that's really important is to be able to query for barriers, so that people can know what are all the things that are stopping the patients from getting the services or doing, getting their medications or meeting their goals. So these are all requirements that Fire Eye or Lloyd is telling us that extensions are able to do. So that we've had conversations about this, and this is where we really need some feedback, because I did, Stephen showed them some of the use cases that you documented, and I pointed to it, and I had to create a JIRA, which I created in order for them to be able to start to build this extension. So it would be sort of like a workflow type extension that goes across multiple resources, not just on one particular resource.
So does it mean that the current fire extension thing will need to be revamped to accommodate the use cases that we come up with?
No, so Lloyd was saying that when you do the structure definition for an extension, that all of these criteria or these requirements can be done on an extension today, as it exists today.
Hey, Emma, is there no need for any other data about the barrier, like when it applies or how bad it is, or any other decorations on the reference to whatever it is?
Yeah, so I think what they're saying is, if, say for example, the barrier, you construct your barrier as an observation, where you put in the attributes of timing and who and what and when and where, all those other things, then you can use the reference and point to it. So you can say this observation is a barrier, and that's what the extension will do for you.
Okay, so you can use the reference to point to an observation, but you can't use the observation profile to represent barriers and supporting factors.
Exactly, because he keeps telling me what did he say? The reference, the thing that came first points to the thing that comes second. That's what.
So also, it seems like the thing that's a barrier is an observation about something that's true first. And the
Yeah,
fact that it is a barrier is a relationship between two things. So it may be.
that's what the extension does. It creates that relationship.
Okay,
But
you
we don't,
kind of
but we don't need to,
mix.
but we don't need to refine that relationship. We can just point and say that's a barrier. You know, we don't need to.
Yeah. So for my example, where I say the person with the osteoarthritis in the knee, and the osteoarthritis in the knee is the thing that is the barrier to them walking 3 miles. So you create the osteoarthritis, which could be a condition, and you reference that condition from this extension.
Right. I'm not thinking
Okay.
even use cases. I'm just wondering if there's not a case where that barrier only blocks you on Mondays. No.
And if you find one, please send it to me because I like to stump Lloyd. Like, what about this?
So if the barrier
Right.
only happens periodically within certain time frame, so therefore you have to use an observation which would allow you to specify the time period for which the barrier applies, and
Yeah.
then with this extension points to the observation.
Yes.
Okay.
And this extension can be on a service request, it can be on a goal, it can be on a medication request, but wherever, whichever, that's what this extension can be on that thing.
Okay.
Okay.
Thanks.
You're welcome. And so I've been working with Jose and I wanted to do the same for protective factors. So we can point to the thing that is a protective factor. So I will update the team, the closer we get to this barrier, to this extension becoming a reality. All right. Karen, can you go to the next slide? So connected time planning. Karen, did you want to talk about the connected time planning track?
Sure. We've scheduled our orientation call, so it's April 27th from 2 to 3 Eastern. And apologies, Stephen, I think that's very early for you. But yeah, so if there's anyone who is planning to join, we have the sign up sheet here and we can send out the meeting invite for that. We've also scheduled our sessions. So I think of note, we'll plan a walkthrough of the IG for any folks who are new. Dave Carlson will do a demo of the CQL use in our care planning apps. So that may be of interest to some folks on this call. And then in the afternoon, we plan to use this for a discussion and testing with some related tracks. And then on day 2, we have an open testing session for a 2-hour block. And I will share the scenario that Emma and Dave Carlson have been working on. And then we've also blocked some additional time for open discussion or continuation of any discussion and testing from earlier on. And in terms of the scenario,
So
I don't
yeah.
know, Emma, if there's anything you wanted to call out.
So yes, Laura, the scenario is the same scenario that we're using in Clinician on Fire. Remember Betsy and her diet? But because my goal is for us to really be, how should we say, really be together from the Clinician on Fire with the clinical and the technical, you know what I'm saying, as we try to go through all of these. So this is heavily, it is Betsy's stuff. And right this time around, what we're trying to focus on is interventions and trying to keep the interventions real. You know what I mean? Like really what people are capturing in their systems and things like that. Because David and I had a good conversation the other day about what does note mean? What is notes? And I'm like, it's a progress note. You know what I'm, so those kinds of things. So that's how come we have these like technical connected type questions. How would you, this is collected in your system. How is it shared with fire? That kind of thing. So these are some of the conversations that we're technical type conversations that we're having that goes hand in hand with the functional conversations. And we did, we are continuing to talk about goals, continuing to talk about interventions, and I keep pointing out to Dave is that the thing about goal is goal does not just live alone in a bubble by itself. Goal is hooked up to other things around it. So we always have to be very cognizant and mindful of that. So if, and again, the track page is out here. Anybody who, Jay, did you come in and leave again and came back?
I think he left.
Oh, okay. Because then I think he just.
No, he's coming
No, I
back.
think he's coming back. I think he has connection problem, keeps on dropping.
I'm back, I think.
I was like, I know you came in before. But anyways, again, please, this is all collaborative. We really, really do want to, make sure that this works. Karen, can you go back to that slide? The other part that I get excited about is CQL. So for folks who, if you remember Bryn Rose and some of the work that Bryn's been doing with CQL, this is how we're actually trying to use CQL in the care planning app in order to present the data in a clinically useful way. And I think this is really, really interesting. So for people who are care plan groupies, I get excited about it when Dave and I, we talk about how CQL can be used to do different things. So please, if you have time to participate or to come on and listen to that part of the track would be really useful to ask, clinical type questions. Because I remember years ago, probably when I first met Dave and he was working on CQL, and he's like, this is, I keep saying it, Karen's like, don't say it like that. He's like, it's a language that clinicians that is I don't want to say it this way, that non-technical people can understand, So that's one part I think people should be, have some interest in listening in on as far as the track schedule. Any questions about Connected Home? All right. Okay, so as you guys may, yeah, there you go. So we had USCDI V3 is out for public comments. And I think the last date for us to provide public comment to them is April 30th. And this is where we're trying to provide comments on what is currently out there in USCDI, and if there are any changes or any updates or anything that's needed to be done. I don't know if people follow this, but remember USCDI at one point, I think in V2, we had care plan, and then they broke it out into assessment and plan of treatment. So it's those kinds of comments. Yeah, there you go. Thanks, Karen. I was trying to look that up. Yeah, so now it's broken out. The care plan went away, and then it became assessment and plan of treatment, and then there's definition for assessment and plan of treatment. So what we're looking for is there from patient care work group or interested parties, are there anything in our approach to care plan that we think need to be included or need to be updated in USCDI? Because it doesn't call out for like a structured care plan, for example. There is
this is a big question, Emma. I mean,
Yeah.
because what do they vision plan of treatment to be? I mean, I really appreciate you and your teams articulating this and bringing this to this group. Thank you for that. But what is, I haven't studied it. I'm just like, what do they think is going to go in here? I mean, is this I mean, I remember talking about this a few weeks ago, how they lumped them together. But what exactly do they think we're actually going to do with that? Because even just if I was thinking assessment in my head, let alone plan of treatment, either one of them is like, and yeah, what? I mean, what are you going to do with this? Just a big glob of text or something? I'm not
That's
clear.
that's the feedback that I think they need, because right now, when you look at US core profile for care plan, it is a big blob of text. And that's why,
And
you
what
know,
is it for assessment? Is assessment a big
I
glob of
think,
text?
no, I think, and that's just it, when we do it, when a lot of people are, when I hear about assessment in profiles, we're talking about questionnaires and questionnaire responses, those kinds of things. You know, the prepare tool and, you know, those, that kind of thing is what people are using as assessment.
So screeners? I mean, screening tools is assessment?
Yeah,
I think, aren't these different?
so that's the act of, I keep saying that there's an act of assessing, which is a screening
Yeah.
tool, and then there are the results of the assessment, which may be an observation or something.
But doesn't, I mean, if we say assessment instrument and plan of treatment, it means figure
And
out what the plan should be,
That's the
which
sort
could
of feedback we
could
probably,
include different.
Yeah, unfortunately, questionnaire and questionnaire response are very simplistic worldview of the concept of assessment. When you look at comprehensive assessment, which would allow you to discern a patient's health concern or problems, and also then reaching some kind of health goals, the assessment piece is far more complex than just using some instruments like questionnaire and questionnaire response. So I'm not particularly sure where this is heading if that is the focus.
and that's what we need to provide comments to them about.
So we
Like,
need to, I mean, I even started the black text underneath that assessment plan represents a health professional's conclusions and working assumptions. So I think that's the part they're saying is the assessment. And then it talks about and guide treatment of the patient. So that's the plan of treatment. So I'm not sure that the word assessment rings to me with the professional's conclusions and working assumptions are.
This is Lincoln Weed. I think this is another example of how it's useful to look at how these issues are treated in the problem-oriented medical record approach. There,
Mhm.
in the SOAP note, you know, the A is for assessment. That's completely different from like an initial screening assessment for an initial database. For an assessment in a SOAP note, you're doing that on a particular problem. And you know, that kind of specific assessment then becomes much more manageable and understandable by everyone. And you're assessing, what you're assessing depends on where you are in the care process. If you've just gotten test results, then you're assessing the meaning of those results and their implications for what you do next. If you're doing the initial history and physical, or if you've just done those, then you're assessing what those show and what they suggest should be done for the initial care plan. And you know, similarly, the entire care plan is on a problem-specific basis. And that doesn't mean you can't consider relationships to other problems. Part of care planning is systematically considering that problem first in isolation and then how it relates to the other problems and other plans. But I think everything becomes more manageable, you know, if it is done on a problem-specific basis. And part of what you could do, you know, because of the flexibility of a computer record versus a paper record, is you could display all plans for all problems, you know, on one screen, and then look for, or with your colleagues, discuss the interrelationships of those care plans. Or you can be looking at one care plan for one problem and then consider the whole problem list and discuss whatever connections you might see to other problems. But Laura, you were expressing bewilderment is what you do with this just big aggregate assessment and plan of treatment. And I think that difficulty somewhat goes away if you do things on a problem specific basis.
Lincoln, I admire what you are trying to say, but I think I have to disagree on a certain levels. The assessment process is itself is a holistic, should be a holistic approach. It's not a sort of a specific to an individual problem, because that's where the problem arises. You decompose the patients into a set of problems. So what it needs to be done is a holistic assessment of the patient, and the process itself needs to be holistic. And after the holistic assessment, then you discern the health concern or the problems, and how you document it is a different story altogether. But the process of assessment itself needs to be holistic.
But I think it's sort of the other way around. You get to the holistic assessment by being aware of the specifics of assessment on each problem, and then you can put all that together. If you start at the holistic end, then you don't know what you're missing. You don't have the details to put together holistically. It becomes very less systematic, less rigorous if you start with a holistic assessment. You have to know what's there before you can put it all together in a holistic way. And that's the idea of the problem list and the problem-oriented record. You can do that. You can organize that assessment activity by looking at each problem and then considering each problem in relation to the others, and that gives you the holistic view.
We can. All right, go ahead, Laura.
I think, I mean, I'm somewhat familiar with the problem-oriented record because of stuff that Intermountain did in the past. So I kind of understand that. And I'd like to schedule some time with this team on a Wednesday if Lincoln can come, and we really dive into the problem-oriented record and kind of the discussions we've had around care plans, et cetera, because I think we're actually I think it's going to be workable and it's synergistic. It's just we have some different communications on how we think of it right now. And some of that ways that we think about it, I think, is different ways people practice. And I think they're all kind of reasonable ways to practice. I think the problem-oriented approach is a very strong, and many people practice that way, but there are other people who don't, and they may not yet. And I understand that, perhaps we should be campaigning and helping everybody understand why that's a best way to practice. But that's not our issue today. And I'm not saying I'm unwilling to talk about it. I'm just not sure today that's where we should go. But when I'm looking at what we see on the screen and hearing even problems, is that USCDI in itself has so many issues. Because if you look at where it has problems up in the top right, health concerns in the middle, and then this wacky thing that we don't even know what we're doing with it over in the assessment and plan of treatment, that if you take all these multiple threads of everybody on this call coming at this, looking at us, I still think we all have a huge problem between problems, health status, and assessment and plan of treatment, and how we're actually going to use USCDI. So
I really totally agree with that. And I really think the problem-oriented approach can resolve a lot of that confusion. And there's a couple of practitioners who should be on such a call to discuss it, who I can tell you about. But that's,
and I think we should. I mean, I really do think we should dive into that with the care plan team that's looking at this, and see if we can resolve some of this. But and I agree that I think the problem-oriented approach could help with some of the framing here around USCDI. But like I said, I mean, even with USCDI, if we take at it and just look at it, the problem approach, which I don't know if everybody on this can follow that because I'm not sure how well they know it. Like, I'm not even sure how we would do the problems. I mean, if you look at health status on USCDI, are they trying to say the health concerns is how you're prioritizing the problems? I don't even know that I can call that out and say that's true. I mean, that's a big link of brokenness to me right there. But then there's also, again, coming back to the assessment and plan of treatment, and then on the assessment piece itself. Now, assessment, I think, is this maybe overused term, because screening is a type of assessment. And so right now what's getting included in there is a lot of screening type tools, just hearing what Emma has said and what clicking on these things. But that's not what's said in the black text that's describing it. I mean, saying that the health professional's conclusions and working assumptions and calling that the assessment, I'm not sure that I've seen that definition used anywhere readily in the health, like in our health informatics world. And just greatly, I mean, teach me or can correct me, but it's just not something I'm used to seeing.
Yeah, Laura, I agree with you that block of black text representing health professional conclusion is what is the end point, what the end point of representing in, if you look at FHIR, the clinical impression is what it is representing that end point.
Right.
And itself, and as I said, the assessment itself, there is the sort of process and also the tools and also the endpoint, which is what I want to call clinical impression. What I want to call clinical assessment outcome, but now it becomes sort of clinical impression. So that first sentence, or that first part of the sentence is actually sort of representing the endpoint of the clinical impression.
Both the terms
And so then
impression.
I could.
Well, I was just going to say both the terms impression and assessment raise the question: impression of what? Impression and assessment of what?
And that's the reason why the clinical impression resource is at very low level of maturity. We still haven't sort of settled that. If I have my way, I wouldn't use the concept impression, but that's another discussion for another day.
I'm not seeing the text or the sentence you were just referring to, the black. Is that on the screen now?
So in the box over on the left, it says assessment and plan of treatment. And then it goes into black text that says represents a health professional's conclusions and working assumptions that will guide the treatment of the patient.
Oh, okay. I
feel like that's trying to describe the header. And I'm kind of stuck on that. Like if, because to me, the word assessment has many meanings, but it's never coming up with the first half of that paragraph, of that black text paragraph that's highlighted. I mean, assessment can be, because, nurses use assessment as the term to describe what essentially physicians say is a physical exam. And yet, I mean, in screening tools, as is being interpreted here through the SDOH example and such, screening is a form of assessment. I mean, that is a tool and things we do, but I just kind of really stuck on that box a little bit there. And then, let alone the plan of treatment, I mean, if we're to say what's missing, like to go back to the first question I think Emma had for us, what's missing that we should say goes into that middle box with that title assessment plan of treatment that would end up as the lighter blue text and in a row of things or a column of things under assessment plan of treatment SDOH. I mean, we could put a whole row of things in there that we would consider plan of treatment things, but I don't know if that helps.
Yeah, no,
I think
the things in the lighter blue are the data elements. The dark blue is the data class.
Laura, the way that I see it, the assessment and plan, it is being taken sort of as the last two words of the SOAP. So we have subjective, objective, and assessment and plan. And that assessment, where you read the text representing a health professional's conclusion and working assumption, that is exactly what in the SOAP note the assessment is about. And then the plan will be the second part to guide the treatment of the patient. So that's the P of the SOAP note. So I
Okay.
think that's
That's
how
right.
how it is being crafted. And I think that you're looking at a piecemeal sort of like way of representing sort of assessment and plan. But that's a question that we need to pose to the US CDI folks and ask them sort of like, how do you sort of come to that conclusion that the assessment is just only this part?
Well, I
Well, I don't
just,
think they do. I think it's
that-
ambiguous. And they need to
terms of the-
clarify that.
just as a
Jay,
little
and then Lincoln.
historical background
Yeah.
on SOAP notes,
Mhm.
my father conceived that as on a problem specific basis. You're writing a SOAP note
Mhm.
about a problem and assessing that problem and coming up with a plan for the next step on that problem. And again, I think, a lot of confusion can go away if we think of it on that basis. And that's compatible with, and it enhances the holistic approach. At first glance, it may seem unduly to compartmentalize things, but the compartmentalization is a necessary step in order to get a holistic view that's rigorous and systematic.
So
And-
Lincoln, let's just go down the problem-oriented a minute here and see what you would say on, so if we're doing the problem-oriented approach, you've got the problem piece stated over in the top right.
Yep.
And then you want to, do, as you were just saying, a SOAP type of thing, attached to that problem. And objective, I'm not even sure they have that in here anywhere. I have to go over to my other page here.
The clinical tests, labs.
Yeah, basically.
Yeah, but
Subjective and objective is meant to distinguish between what the patient is experiencing, symptoms basically, and then objective is information that comes from, tests, imaging, some source other than the patient. Another, you might say symptomatic and other rather than subjective and objective, because subjective is sort of a pejorative term and it gives undue weight to tests and images and that kind of thing.
So the
So
question.
do they have subjective even in here anywhere? Like if we were going to follow the
No,
approach,
there
and I just
isn't.
yes or no, and
There-
we'll move on.
There
Yeah, well, I
isn't
think
anything about
I think it's
subjective.
fine. I think it's fine to stay away from the terms subjective and objective because they do have sort of favorable and unfavorable connotations. I'd say just
Uh-huh.
symptomatic / patient sourced, and then
Yeah.
other sources.
Uh-huh.
The
And that-
subjective
So
is actually
the-
the subjective is actually more than the symptomatic things. It's also including the histories that sort of you get from the patient.
Well, that's the way, again, the way it was originally conceived in the problem-oriented record is that you would collect an initial data set on the problem, which would consist of the patient and family history, the physical exam results, and basic lab test results. And then in follow-up encounters, you would do further investigation by, doing further exams, further tests, whatever is needed in the circumstances. And those further results would typically be characterized as either subjective or objective. And then you would then assess those results, the A in the SOAP note, and then modify or continue your planning based on what your assessment. So that's a sort of an iterative process. You keep redoing it and revisiting your plan based on the new information and the corrective adjustments that are needed.
So from a priority use case perspective of shared care planning and dynamic longitudinal care plans, what data elements you think we should add, usually ask USCDI to add to this list?
Well,
Yeah.
I think we'd have to go through the domain analysis model and check them off and say there's a lot of things that are covered already in here because, I mean, some of the basic things that like the problem, some things like that are covered. But then when you get to some of our other things that are very important to care planning, like you were just talking about barriers and things, do we think USCDI covers it or not?
Yeah, so
Not sure.
in the care planning, Karen, can you go back to the UDA? Yes, maybe we need to add a data element for barriers. Barriers to care.
Right. I mean, that's I'd have to pull up our data element list from the domain analysis model to kind of say, you know, and just do a check mark type thing and saying, okay, this is important to our care plan visions. Is it in USCDI? And I'm guessing we're going to find a few things that are not.
Yeah,
But selfishly speaking, diet and nutrition is not in USCDI.
it is. So if you go on to it is. So
It's level 2, but it is not in USCDI. So if you're looking at it purely from what are the versions of USCDI, it's not in the official USCDI.
So maybe that's a comment. We need to pull it out of level 2 and put it up into the official USCDI.
Because I'm the one that
argue to
added all
pull it
those.
out of the levels into the version 3 when they go with 3.
I
Yeah.
would love
I mean, how
that.
does anything come out of level 1 or level 2 into version 3? I mean,
So
what-
you submit
how does it make
comments to request data
Mhm.
elements, and I submitted comments the past 2 years, the second year being this past year, for that whole new nutrition and diet class. Now, the one thing that's not in there is allergies, because I submitted that the year before for food allergies. And I'm going to assume it's members of the high tech, or maybe it's ONC. I'm not sure which does it, but they look at it and they classify it from comment level, level 1, level 2, with level 2 being those that are widely used and have, I think it's like more definition around them. And then they consider everything that they've classified as a level 2 for the next version of USCDI. So what that means is I got classified as level 2, which is great, it's being used, but they didn't feel it was used enough or important enough to go into USCDI. That's my interpretation of it all.
But maybe we argue that it needs to go into V3, is what you're saying.
Yes, I'd be all for that.
Because you see that the food allergies ended up into the top on the level 2, it's in the allergies and intolerances, it says there. Yeah.
Correct.
Okay.
That's where we had submitted it. So the one that says substance food is my submission. The one that says substance non-medication was another person's submission, and they lumped together environmental allergies and food allergies because what they put in the original USCDI was just medication allergies.
Okay, so I say two approaches here is that, first of all, we do kind of a checklist based on all of the data elements we've talked about in the past that we think are important to care plan and care planning, and check them off, see where are they right now. Are they anywhere in the considered for version 3? Are they in level 1? Are they in level 2? And if not, we submit them and see how far they get. And if they're on, especially level 2, then we argue how much we'd like that to go into version 3, right? But I think we're gonna have to do some
they tend to want
other homework.
They tend to want pretty mature stuff. I think we did the medication usage code that is in R5 and FHIR, but they didn't think that was mature enough, and so it's sort of in the queue.
Do we know how they determine them for themselves? What the maturity
Not really. Not really. I think if you have evidence that there is a specification or a value set and that it is in use already out in the wild, then that's going to carry weight. And if it's something that we're saying we think this is how people should do it, it's going to be less of a priority.
It may not carry enough weight because within my submission for nutrition and diet classes, I cited different resources not, I shouldn't say just resources. So we have the fire nutrition order, but what we found when we did a quick analysis with some of my dietitian committee members, they had stated that V2 standards are widely in use. And so I did cite all those in there because that's still a standard that's being used. And then I named all the different value sets that we had for the different elements that I wanted to see in there, and I still didn't make it into USCDI.
Well,
So
I think it's pretty commendable you're in level 2.
Oh, well, so do I. Thank you. I just want to go all the way.
Yeah, no, I get that. To me, USCDI is a very important body of work that's on a good trajectory, but its usability at the moment is fairly low. And so we need to keep at this process and, keep working on it. That's why I'm not too worried that you're not in it yet, because I don't know how. It's one of those things to me when I look, 20 years from now, we're going to look back and say, oh my gosh, how far we've come. And we just have to realize we're a little bit in what may be considered the dark ages of this topic, but we're working and fighting hard at it. Do you see what I mean?
Right.
So, yeah.
So is someone going to write a comment for your plan of care, plan of treatment?
Yeah, okay, so what did we say? This is due April 30th? Yeah.
If so, I have some draft language in the chat.
Oh, okay, let me grab that, because I'd like to take a time to just look and think at this a little bit. So I'll grab your chat. I don't know that I have the answers to it. My brain is just kind of fuddling through this, kind of going, oh my gosh, it's so far from anything that I look at as useful, that how do we help step it along?
Yeah, and the description of health status is problematic too.
Yeah. And part of it is I didn't comment this last time because I got so frustrated with the first time that I commented on stuff that I just I think I was in denial and ignoring it this last time around because I was so like, oh, this is so frustrating. It's getting nowhere.
Yeah, the black text.
I realize now it's just going to take a long time.
Yeah, the black text after health status is more indicative of health concern rather than health status.
Mm-hmm.
Anyway, there is a lot of comment, quite a fair bit of issues here, a lot of comment that we need to put in. So I think we probably need to revisit it in one of the calls, to look at how to respond to that. Some homework needs to be done, documenting the issues, and then we come back to a call to discuss before the 30th of April deadline.
We could continue this conversation on our Monday call if people are able to attend.
Well, but Monday we only have a fortnightly call Monday, and we have a lot of administrative stuff to discuss. So I'm not opposing to that, but I'm just saying that if we do it on the Monday call, we might not have enough time to unpack everything and then draft some responses.
Yeah, so maybe we come up with a plan on Monday call.
That'd be good. Yes. So this
Either
coming
that or add
Monday,
a Monday
right?
call, like you said, we only have them every other week or so.
Yeah, so we can add 2 calls on the Monday, and then we can discuss that. I think that is also a plan. So this coming Monday there is a call. Is that right, Emma?
Yeah, we have a
yes. So
yeah.
Can you put in an agenda item to do some planning on the Monday call? And if we decided that we want to use the other Monday, we can do that. And then any flow over, we can then take the clinician on file call as well.
Okay, I can do that.
Yeah, let's do that.
This is Lincoln. I think it'd be useful to have a discussion focused on the problem-oriented approach and what it is and what it means for everything else you're dealing with. You might maybe call one of the problem-oriented record teams project teams, biweekly calls could be used for that, and anyone from this group, could be sort of a joint call. And you wouldn't have to, disturb your other the rest of your schedule, which is obviously fully booked.
Well, part of the reason that we have all the call on the sort of weekday 5 p.m. US Eastern is to accommodate me, and I'm highly appreciative of that. And any call that is much earlier will make it very difficult for me to join the call.
Okay, well, yeah, obviously I want to have you on. Well, there's two practitioners in particular, two clinicians who worked with my father for many decades, and they really know what the problem oriented record is all about. I think they could both be available for a 5 o'clock call or whenever anyone wants. Maybe just a few people like you and Laura, whoever's interested in that. But I think they have a lot to contribute here.
Yeah.
Well,
It sounds like it
So-
would be a decent topic for the care plan series on Wednesdays. I mean,
Yes, very
I
much.
think it would be, and I was gonna say, Jay, is there, because currently you help guide our discussions. And so looking between now and, come the end of May, or, the working group meeting, it's a fruit basket upset and we redo this whole schedule and we could schedule it then. But if we want to do it before, I don't know that I would ask the EMCC team, anybody could volunteer to say, hey, let's take this Wednesday, but I'm kind of pointed out asking Jay if he thinks we could take either the 6th or the 20th. But if EMCC would like to talk about and see if they'd like to take one of their days, either 13th or 27th, to.
if we did this on the 6th, it would give me more time to prepare for the 20th.
Well, so Lincoln, do you want to talk to your guys and see if they could join us here at this time on the 6th?
Yes. 5 o'clock on April 6th.
Yeah. Mm-hmm.
Okay.
When the recording of this call is available, I'll give them a link to that, and that'll sort of help get them up to speed.
Okay,
Mm-hmm.
we'll make sure to post that and send an email out that it's been posted.
So there are 3 topics that we are grappling. One is the feedback to the USCDI version 3, and then we have the problem-oriented medical records, and also we have the care plan issues. So I think come Monday, Emma, I suggest that we do a bit of planning and talk about sort of the response to the USCDI. And we do need to schedule a time to talk about the problem-oriented call, which I think we can do it on a Tuesday if we run out of time. And then Wednesday, I think we have a tight schedule to talk about care plan stuff. I think I would suggest that we keep a sort of a Wednesday call focus on care plan. And if we want to appropriate some other time, probably Tuesday, sort of 5 p.m., we can appropriate it for problem-oriented medical record topic. So Laura, what do you think?
So Stephen, I think that Jay just said that we could maybe use the 6th of April.
Okay, sure.
So
Yeah,
I
that would be fine.
Put
Yeah.
it in here as tentative based on if Lincoln's team can join us.
All right.
As tentative this, and then to the MCC folks right now, I'm gonna maybe say we talk a little bit more about USCDI. Again, like you planned today, you put it at the end of your topics. If you could do that again on the 13th, that gives us time to turn around before April 30th.
Right. So
So,
you think that we don't need the alternate Monday call to talk more about the USCDI feedback?
Well,
I don't think it's gonna happen this coming Monday, and so it gives
no,
us.
I think on
some time.
Monday, this coming Monday, I added it to the Monday call agenda for us to plan
Okay,
the strategy for the analyzing of, how we're gonna go about analyzing what we need to come up with a plan, like look through the domain analysis model or, those kinds of things.
okay.
Okay, sounds good.
Okay,
So I think we have it. Okay.
All right, we are at time.
All
Laura?
right. Yes, we are.
we are, well,
Again.
this is great conversation, by the way, and please, that we can still submit comments, because everybody can submit their own comments on their own as well. so if, you know, to USCDI, but we would definitely come up with a strategy and a plan for submitting from patient care work group and the care plan folks. Any questions, any concerns, anything for the MCC team as we move forward? If not, thanks everybody. Thanks for your support and for listening to us. And we are in the process of planning Connect-a-thon, so please join us for that.
You guys are doing wonderful work, Emma. I think that sort of the effort needs to be acknowledged a lot more. I will try to see whether or not I can take myself out of the bed to do a night shift to join your to join your Connect-a-thon, but I will think about it.
Thanks, Steven. Thank you so much. Thanks, everybody.
Thank you.
Thank you.
Thank you.
Bye.
Bye.
Bye.